Recurrent cancer, how to keep balance. Thyroid cancer is one of the most prevalent solid tumor. Papillary thyroid cancer, most of our talk about papillary because it represents more than 80% of all thyroid malignancy. It is a most indolent disease. Surgery is a mainstay line of treatment. 5-year survival is 94, 10-year survival is 89, and 20 years is 87. Cervical lymph node metastasis is most common, especially central. Central neck compartment is considered to be the primary icon of lymph node metastasis. Occult metastasis من 20 to 90%. Local regional recurrence reach up to 30%. Most of our cases about this 10 to 12 percent of thyroid cancer exhibit aggressive behavior and don't follow an indolent course. Clinician must identify tumor with more aggressive biology and treat them according with more aggressive regimen. The complication of thyroid surgery are directly proportional to the extent of thyroidectomy and lymph node dissection and inversely proportional to the surgery experience. Some of complication may be much worse than the disease itself, such as recurrent laryngeal nerve and permanent hypoparathyroidism. Reoperation for papillary thyroid cancer recurrence increase surgical complication and medical cost and affect quality of life. Optimal extent of thyroid resection and lymph node resection up till now remain controversial. We invest surgical complication after thyroid cancer surgery and association between the extent of surgery and the complication through about 200 patients we operate in South Egypt Cancer Institute. There is many regimen to assess the thyroid cancer like age, extent, extrathyroid, multifocality. Either the other group is completely healthy or affected. There is extrathyroid extension or not, and the size of the tumor, it is less than 1 centimeter, 1 to 4 or more 4 centimeter. What about thyroid surgery? Either we do hemithyroidectomy or near total thyroidectomy. We against totally what is called the subtotal thyroidectomy. Subtotal, you leave part of the thyroid in right and left, but near total is accepted in low grade malignancy. In total thyroidectomy, don't miss the pyramidal lobe. Total thyroidectomy has many advantages in papillary thyroid cancer. It allows for follow-up the patient through tumor marker like thyroglobulin and anti-thyroglobulin. It can give the chance to give radioactive iodine. It can give the chance not reoperate second time. But when you do total thyroidectomy, the thyroid scan postoperative must say that post-thyroid cancer reveal no thyroid residual. The most common complication comes from recurrent laryngeal nerve. You should explore and dissect the recurrent laryngeal nerve. You should do what is called extracapsular dissection of inferior thyroid artery. This is a case of recurrent laryngeal nerve with non-recurrent, which is occur in the right side mainly. Modern technology and using of clips and harmonic decrease the complication as regards the recurrent laryngeal nerve and parathyroid gland. That is very important to keep parathyroid in place with good blood supply and to do dissect the recurrent laryngeal nerve. Very important also to dissect the inferior parathyroid gland and superior parathyroid gland because there is a transient hypocalcemia and permanent hypoparathyroidism. Permanent hypoparathyroidism, if we fail to correct autonomous by 6 months, there is actually a 4 parathyroid must be kept in place with intact blood supply. In the past, we ligate the inferior thyroid artery, but now we must do what is called extracapsular isolated ligation of branches of inferior thyroid artery. Keep the parathyroid all the time, and if by mistake you take the parathyroid with the specimen, you should re-implant the parathyroid either in sternomastoid muscle or in there is actually a recurrent laryngeal nerve and the parathyroid. All the time you should dissect the recurrent laryngeal nerve up to Ver's ligament. You keep the blood supply of the parathyroid intact. We now come to the lymphadenectomy in papillary thyroid cancer. We see that occult lymph node can reach up to 90%, and it is the main cause of recurrence. So that there is a central lymph node or level 6. It extends from hyoid bone up to suprasternal and carotid bilateral, and it should be recommended to do either ipsilateral or bilateral central lymph node, and you have to dissect the recurrent laryngeal nerve and inferior parathyroid. That is actually the central lymph node. In my opinion, at least for papillary thyroid cancer, you do a total thyroidectomy and central lymph node. And also there is a new classification of level 6, either 6A or 6B, according it anterior or posterior to recurrent laryngeal nerve. What about the lateral node? Most textbooks recommend that lateral node is only dissected ipsilateral or bilateral according it is preoperative or intraoperative diagnosed or by radiology. There is actually a lateral lymph node can reach huge size and can be diagnosed by thyroid SNAR, CT, or scan preoperative or discovered intraoperative. There is actually the extent of lateral lymph node. There is actually level 2, 3, 4. There is a common carotid artery and there is a ternajugular vein. Either you can do it bilateral. In this case, we do a total thyroidectomy with a modified radical neck dissection type 3. We preserve the sternocleidomastoid, ternajugular vein, and the common carotid artery. What about level 1? The thyroid lymph node metastasis is there in the level 1, and if we do a level 1 dissection, you should preserve the hypoglossal and lingual nerve. There is actually a bilateral modified radical neck dissection. It should send for subpathologist every level from the lymph node separate for proper diagnosis. There is about a 10% of difficult cases. This lady is papillary thyroid cancer, but it is invade the left vocal cord. So that in this case we do a total thyroidectomy and we sacrifice the internal jugular vein and sternocleidomastoid muscle, and it is more than 5 years survival now. There is another case with we do a total thyroidectomy, bilateral neck dissection, and also we add shaving of the trachea until we reach the negative by frozen section. There is a case of recurrent thyroid, and we had to do a 2-ring tracheal resection. There is a case with scalp metastasis after we do a total thyroidectomy by 3 years. There is a case of level 7 or superior mediastinal lymph node metastasis, and also there is a innominate artery and innominate vein. There is another case of lymph node metastasis. As we see, we completely open the superior mediastinum. There is a usual scenario. We see that the patient of thyroid cancer do some sort of thyroidectomy. We have to do a completion thyroidectomy with bilateral modified radical neck dissection, and we see that redo surgery or revision surgery is more difficult than the primary surgery. There is a case do a total thyroidectomy with picking of the lymph node and take also radioactive iodine. We want to confirm that radioactive iodine does not improve survival if inadequate surgery was done. We now do what is called the transverse neck incision, and by this incision we can do a total thyroidectomy with a bilateral modified neck dissection, and it is cosmetically better than previously apron incision. My conclusion, at least for papillary thyroid cancer, you do a total thyroidectomy with level 6 lymphadenectomy, and if there is a bilateral node, you do bilateral modified radical neck dissection. We do this operation at least to prevent view of this recurrent cases. Thank you.